right, hello everyone, and welcome to today's Teach Educational Round session. My name is Tanya Abate, and I'm with the Teach Project. Today's session is Tobacco Cessation Efforts in a Cancer Care Setting, Lessons Learned in Program Implementation. Our faculty presenter today is Dr. Meredith Giuliani. If you are interested in obtaining a letter of completion for today's session, you must have registered for the webinar and completed the pre-learning assessment. You must sign in to view the live webinar session using your first and last name. And if you have joined us as a group today, please be sure to email me by end of day today in order to record your attendance. As well, the last component is to complete the evaluation and post-learning assessment, which will be emailed out to everyone by the end of day today. These webinars are being live tweeted through Twitter. Follow the CAMH Nicotine Dependence Service on Twitter at @PSQuitSmoking. To follow the live tweeting or to post your questions, please use the following hashtag #TeachWebinar. So our faculty presenter today is Dr. Meredith Giuliani. She's an assistant professor in the University of Toronto, Department of Radiation Oncology, and a radiation oncologist in the Radiation Medicine Program at Princess Margaret Cancer Centre. She received her MBBS qualification from the University of London, England, and her Masters of Education from the University of Toronto. She completed her residency training at the She completed her residency training at the University of Toronto, and she's the chair of the Canadian Association of Radiation Oncology's Education Committee and the director of undergraduate education for the Department of Radiation Oncology at U of T, the medical director of education for Princess Margaret, and the Cancer Care Ontario Smoking Cessation champion for Toronto Central South. Her clinical interests include lung cancer, head and neck cancers, and endocrine cancers. Is anyone else having difficulty with the audio?
How's this? Is this any better? Okay, perfect. So I've connected through the computer, which means if you've dialed in through the teleconference only, just let us know if there are any issues. Ooh. Is there still feedback?
Conference is now in talk mode. New conferees will be unmuted. Use *1 to unmute your line.
Okay, so we're going to forego the teleconference line. I hope that's all right with everyone. Megan or Perzad, if you could please type that into the chat box just in case anyone can't hear. We'll have to just use the microphone. I apologize for this, everyone. I'm just going to make sure some people write some comments if everything's okay here to proceed.
Still not doing butter on it.
Okay, perfect.
Your transfer just really slow.
Okay, moving along. Disclosures. These
Yeah,
are Dr. Giuliani's disclosures.
Thanks.
The Teach curriculum and slides were developed and compiled with funding from the Government of Ontario, Ministry of Health and Long-Term Care. The content of the slides are primarily based on evidence-based guidelines from the following 3 sources. These materials, as well as the verbal presentation and any discussions, set out only general principles and approaches to assessment and treatment and do not replace the need for individualized clinical assessment and treatment plans by healthcare providers. Now, before I hand it off to Dr. Giuliani, I just have a couple of polling questions here that I'd like to ask. So the first question is, what region does your organization serve? Okay, great. So it looks like there's almost a pretty even split between the Greater Toronto area as well as outside of the province of Ontario. If you are from outside of the province of Ontario, if you wouldn't mind typing into the chat box where you're from, that would be great. Okay, the next question is, what is your current discipline? It's a very long list, so be sure you're scrolling down to the bottom. Pretty wide mix, lots of health promoters, educators, managers, coordinators, pharmacists, and registered nurses. Perfect. And the last question is asking the type of organization you work for. Cool. So it looks like about half the group is from a hospital. Thank you for participating in the polls. It just gives us a better sense of the group that's with us today. So without further ado, I'm going to hand it off to Dr. Giuliani.
Thank you, everyone. So if there's any trouble with the audio going forward, if you just type it into the feed, Tanya will come back and help us try to correct it. If you'd like to ask any questions as we go through, that's fine, or we can save them to the end. Apologies if I miss your question, if the feed fills up very quickly. So what we're hoping to go over today, so some of the evidence for the benefit of tobacco cessation. I don't think that everybody here is a cancer professional, so we'll just do some quick background, look at some principles for tobacco cessation implementation, and I'll share with you some of the things that we learned as we rolled out our program at Princess Margaret, and I'll show you some of the data from our a novel technology platform that we've been piloting as part of the grant. So why does smoking matter? So we know in general it kills 6 million people a year across the globe. Our current prevalence of smoking in Canada is 15%, and that number has been declining since the 1950s, but in more recent years it's really slowing down the rate of decline, and so there is work to be done there. It's the #1 cause of preventable death, and it's a significant risk factor for many cancers. And 1 in 5 cancer patients still smoke when they come and have a cancer diagnosis. So this is a very important problem for those of us that work with patients with cancer, and it's a very significant issue for a large proportion of people and their families. So why is it important to talk about it? So there's good evidence from a multitude of cancer sites that it affects how well the treatments work, so your surgery and your risk of surgical complications, how well radiation works and your chance of being cured with that, and it can interact with different chemotherapy or other systemic agents, so lower survival, worse quality of life, potentially more toxicity, and increased risk of the cancer that you were already diagnosed with coming back. And if you're cured of your cancer, so if you think of young people with lymphomas who are cured with radiation and chemotherapy, significant risks of getting a second cancer. So this is we'll just walk through a few examples. I know you come from diverse backgrounds, so hopefully some of these will resonate with you. But in a cohort of colorectal patients who had surgery, there was increased both morbidity and mortality following surgery for their colon cancer. And in a group of lung cancer patients, much more a higher risk of respiratory complications in patients that were either currently smoking up to the time of their surgery, or if you had a shorter cessation interval. This is a radiation example. So we give a primary radiation treatment to a high dose to treat patients with head and neck cancers. Mucositis is essentially irritation and peeling of the mucosa. It's very painful. It affects people's ability to eat and drink. And so you have a longer duration of that mucositis and sometimes a worse rate of it if you continue to smoke during your cancer treatment. And in patients that had laryngeal cancer, so that's cancers of the voice box, they had a worse voice quality following radiation. And one of the reasons that we use radiation in larynx cancer is try to preserve people's voice functioning and give them a good voice quality. And second cancer, so this is following on for that Hodgkin's disease group of patients, but you can see the very significantly high risk in people that have had Hodgkin's disease treatments and they continue to smoke, lower but still significant if they smoked and then stopped. And non-cancer survival. So once you've had a cancer diagnosis, we have many patients that are cured. They're still at risk of things like heart disease, cerebrovascular disease, COPD, and peripheral vascular disease. And this was some very interesting data. So and this is a low-risk group of prostate cancer patients treated with something called brachytherapy, which is implanted radiation used to cure prostate cancer. And you can see that if patients that continued to smoke, they were really dying of other smoking-related diseases like cardiovascular disease or other non-prostate cancers. And so, you could extrapolate from this and say, in patients that have very curable diseases, their continued smoking may have a more significant impact on their survival. And so there's a real opportunity for us to intervene with these patients and make a difference in their cancer care and in their subsequent quality of life and survival. Most cancer patients are not offered cessation services. I saw as Tanya was doing the introduction, we have a lot of people from Ontario, but we also have people from around the country, and I'm sure that the way in which this is implemented in our different centers is quite variable. And I will go into the Cancer Care Ontario program, which has really led the way in Ontario in bringing this to the forefront and really leading the way in terms of getting services to our patients. So what are some of the principles of implementation that we learned? So I'll set the stage a little bit with where our program came from. And for those of you that aren't familiar with the cancer center that I'm from, we're based in Toronto. We're in the sort of downtown area of Toronto. We treat a very diverse patient population, lots of patients whose primary language may not be English, very diverse diagnosis of cancer, including a graduated population that were treated for pediatric population or now being followed for late effects. We have a very strong survivorship program, and I'll lead into our collaborations with them. We see about 1,000 new patients a month, and about 8 to 10 times that come through in terms of follow-up patients. So it's a very busy place. And we have really a perfect storm when you think about it, because many healthcare professionals are not aware of the benefits of smoking cessation in patients that have cancer. And then even when they are aware, many still have concerns about how best to address cessation in this population. And we've gone through the slides already that really show you that there is a very important impact on not only their cancer care, but their subsequent health. And so you have this this collision of factors that makes it challenging to implement a program. But what were the opportunities? So back in 2012 and 2013, Cancer Care Ontario led the way with the provincial mandated new regulations. And that was really critical in bringing this issue of tobacco cessation to the forefront in cancer patients, giving us common metrics that we could work across the province to try to achieve. And it really helped us galvanize our executive sponsorship, and that was critical to program implementation and change management. We had a lot of motivation from our patients and our families, and I'll show you some of the epidemiological work that was done. We really worked to empower the healthcare professionals from across the program. We felt very strongly about integrating this into the standard of care, not leaving this to one or two people and saying, that was their job and everyone else would carry on with their work as it was before. We really said this is everyone's responsibility. Everybody needs to have an awareness of this. And we really looked for strong collaborators, and I'll outline who some of those are. So just a quick background on Cancer Care Ontario. So this is a provincial organization. They have roadmaps and strategic priorities, and in their strategic priorities for 2011 to 2015, smoking cessation and prevention is really highlighted. And so in 2012, they published their framework for cessation that was shared with all of the regional cancer programs, and there's 14 across our province in Ontario. And a champion for smoking cessation was named in all of those different regional cancer programs, and programs were either enhanced or rolled out in different places. And we had to submit data to them, and that was really one of the motivating factors to get the program off the ground and to be able to audit our practice. And so we started submitting data to them in Q3 of 2013. So what were Cancer Care Ontario looking for? So they were looking for us to screen our new ambulatory cancer patients about their tobacco status and to see if they were current or recent smokers. Oh, I just got a note saying someone's having a hard time hearing, so I'm just going to pause for a minute. Everything's okay? Okay, great. And then we had to look at the proportion that were offered a cessation referral and those who actually accepted the referral. And going along with that program that was happening in the cancer programs, there's the SmokeFree Ontario Act. So this was brought in banning tobacco and electronic cigarettes on hospital grounds. There's been bylaw officer inspections, and there's quite significant fines. So I've listed them there, but there's fines to the individuals and fines to the institution that are quite significant. So there was work in the regional cancer programs happening. There was work across all of the hospitals to become compliant with the SmokeFree Ontario Act. And so our design, so as I said, we were really interested in sustainability. We had a lot of concerns that if the responsibility for this program rested on the shoulders of one or two individuals, it was vulnerable to changeover in staff, to funding changes. So we really wanted to have an integrated model that would survive various budget issues. We looked for strong partners. There were lots of people around Toronto that had very established programs, and we looked to them for guidance. What worked when they implemented, what would they change if they could go back and do it again. We looked at addressing secondhand smoke exposure, and I'll show you some of the data for that. And we really worked with our patients as partners to tell us what would be the most effective way to do this. So I'll just take a second and talk about minimal viable products. So I was at a leadership workshop and someone explained this. This is from the kind of startup company world, and it's where you have enough features to launch a product to really get information about future development. So these two images that I have here, this first image here, you can see there's a sign that says here and it says oil and there's a car parking. So this was from Korea, where there's problems with gasoline consumption and difficulties finding parking spaces, and people actually waste quite a bit of petrol trying to find somewhere to park. And so this was many years ago. They implemented these balloon system where if there was no car in a spot, the balloon would rise up, and you could see that a spot was available, go straight to it and park. And then when you parked, there was essentially a string that would pull the balloon down so that people would see the spot was unavailable. If you think about that, it's a good solution. There are limitations to this. This balloon is obviously vulnerable to damage. Issues with the helium, people running over it, a hole in it, the weather may affect its ability to rise up and down, but a good concept. And I think many people have probably seen, many iterations later of this, which is where you have actually electronic solutions for whether or not there's something available. So when we were deciding on our initial version of our program, you could, I think, try to work out what the perfect solution would be forever. But we decided to launch. We had some tight timelines around that, and we decided to study very closely what was happening, get feedback from our patients and their families, and get feedback from our staff at all levels to try to help us refine the process. And so I would say if you're thinking of implementing a program, one of the most critical things is that there's no perfect solution, and everybody's individual context is different, but having a way to audit what's happening and monitor your data and work with your teams, including your patients and families, and be nimble was really critical to us having a program that continues to improve. So what are common challenges? So I'm not sure if this resonates with other people, but we heard a lot of it's not relevant to our clinic and it's not our job. People in some subspecialist clinics were saying this really belongs in people's general practice. They were unaware of the resources that were already available. There was a lack of training, and people didn't feel confident about opening the door to something that they didn't think they could address completely. There was concerns about the patient relationship and how these can be sensitive topics, and you're meeting someone for the first time, and there were concerns about that, and there was concerns about the documentation burden. We needed to submit information. We needed the whole team to know what had been asked and what had been done for people. There was concerns about being able to do that. So there's two Mythbusters I'm going to address as we go through. One is that around the time of a diagnosis or a new patient visit is not the time to talk about cessation in the cancer context. So we'll debunk that a little bit. And then the second one that I hear a lot is most cancer patients who continue to smoke actually are not interested in quitting, and they have enough going on. And so that's also not true. And I'll show you some data that we found quite useful around that. So our program design, so as I said, we started with an environmental scan. We launched in 2013. We have a multidisciplinary steering committee that really has representations from all aspects of our program. They're critical in not only providing leadership to the various aspects of the team, but also, bringing new ideas, explaining to us how different aspects of the Cancer Center work differently, and how we can have a system that works for everybody. We worked very closely with the team at CAMH. We have a great program here. Our patients were very lucky to be able to access their services. Our pharmacists really took a large leadership role. They received training, they secured education space, and they were instrumental in getting patients timely services, and obviously our close collaboration with Smokers Helpline. And Elixir is our survivorship center at Princess Margaret. It's located at Toronto General Hospital, and I'll come back to that. So our environmental scan, so we looked around to see what resources were there. We looked for our patient education material, both internal and external, and found at the time there wasn't a lot of cancer-specific material, although that has now changed. And we looked for where there were counselors that existed. One of our challenges is that we have a very large catchment area, and some of our cancer starts like head and neck and sarcoma patients come from many places in our province to our center. And so different patients have different needs, and how could we connect them to resources that were going to be, I guess, most accessible and agreeable to them. So resource development. So this is back in 2013. Now many centers have resources. Cancer Care Ontario has also led the way with development of resources, but we developed a cancer-specific e-learning module for patients. It's very short, but it gets across a few very key points for people. We developed a dedicated web page on the Princess Margaret site, and we developed patient education videos, and we had one of our wonderful patients come and share his story, as well as some of the other clinicians, and we developed some specific posters and pamphlets for our clinic waiting rooms. This is the e-module. It basically focuses on how quitting can improve your cancer treatment, some of the data we looked at the beginning of this talk, how it can impact your overall health, and again, giving them information about how to access the programs and supports. And if you're interested in going and clicking through the module, it's available to everybody. You can follow the link that's in the slides here. So these are the videos that are on our website. This first individual is Dr. Jeff Liu. He's a medical oncologist, and this gentleman here was one of our patients, and they really put a positive message out there about why this is important. And this is available on our website as well. And we developed some dedicated pamphlets and posters. These are posters that are present in all of our clinic waiting rooms. And this pamphlet is available in our patient and family library online, and we've now translated it into our top 5 languages for Toronto. And these are some other resources that are already available through the Canadian Cancer Society. And I haven't added the resources from Cancer Care Ontario, but they are available as well. And this is some of the content outline. I don't think we need to go through this in great detail, but when we asked our patients what would be most helpful to you, they said, we know the general information. What we really are interested in now that we have a diagnosis of cancer is how is this specifically affecting my treatment and my prognosis and my quality of life. And so we targeted our materials really to address that question. And this is just an outline of how we designed our patient posters. We worked with our patient education team. We followed the principles of plain language. You can see that there's a lot of use of white space and font and colors. And at the bottom here is our contact information for our various clinics. Our Cancer Care Ontario program focuses on new patients, but all of our resources and our referral systems are available for any of our patients. And we do have quite a number of our patients that are actually in follow-up that are interested in accessing the services. And so we make sure that we make those resources available. This is an outpatient review led by one of our medical students, Kirby Ding. And he looked outside of the cancer program because this was this summer. So the cancer program already has a program running, but we're looking at expanding things throughout our hospital in large. And he surveyed about 150 clinics. We got about a 50% response rate, and we asked them, do you have a standard screening protocol or a way in which you manage the use of tobacco products? And you can see overwhelmingly, the answer was no, there was nothing standard. And so when I go back and say that leadership and what was done by Cancer Care Ontario is very important, is that after that document from Cancer Care Ontario in 2012 and the launch of the program, all the cancer centers could say, yes, there's a screening protocol, certainly for new patients. So this is something we identified in our institution that we need to give guidance to the clinics. And these are the people that small percentage, that 11% said that they did have a routine sort of practice. You can see that the consultation rates and the referral rates are still very, there's a bit of a mix in terms of what's going on once you actually have that information. So you really need to monitor and see what's going on, and you need a way to set some performance metrics and try to move people in the right direction. And those benchmarks are very important. So what are the opportunities for technology? So I'm going to spend the latter half of this presentation showing you our iterative data. So what were the results of the first part of our program, some of the knowledge translation gaps that we identified, and how we're looking at making improvements. So just to deal with the first myth that we talked about, so the time of diagnosis or being a new patient is not the time to talk about cessation. That's a very significant concern that I hear when I talk to various groups, but this is work led by Lawson Ng. At the time, he was a medical student, and now he's an internal medicine resident, and you can see it's been published if you want the full manuscript. But they went and they surveyed patients at our cancer center, and they looked at their cessation rates over time. And you can see this time zero, this big bar here. This is the time of their diagnosis, and this is the sort of peri-diagnostic period prior to actually coming to the center and having their formal diagnosis made. So people are already starting to quit and have an impact in that peri-diagnostic period. But this time as a new patient, this first few months, you can see there's really a precipitous drop. And that's really when a lot of the activities around cessation are happening. There's a slow tail, but a lot of it's in this 6-month window here. And so it is the right time to start talking to people. This is a change in their health state. They are getting a lot of health information and information about their treatment, but there's also a period of high motivation. And then we want to capitalize on that, and people want to talk about it. And so I think we really have a duty to do that. And I'll explain the secondhand exposure aspect of this in a bit. But you can see that it's really the majority in that peri-diagnostic period. So our pilot phase. So as I said, we see about 1,000 new patients a month. It wasn't feasible to launch this program across all of our clinics at the same time. There's other programs that we're launching in various places. And we needed to pilot what we thought was going to be a manageable way to do this. And so we worked with our site group leaders, and we picked three high impact cancer sites. And the reason that I say that is that their proportion of patients that continue to smoke tends to be higher than some of the other sites. So if you look at sites like head and neck and lung, the proportion of people who currently smoke is 20 to 25%, versus in some of the other sites like sarcoma and breast, it's often much lower, 10 to 12%. So we were going to be having a little bit richer experience in terms of getting information. We had high motivation from the clinicians in that site. And we needed to pilot. We needed to pilot our questions. We'd worked with our patient education department to phrase the education and the questions in a way that was understandable and used plain language. We needed to pilot our data collection process. We had a large information sort of rollout across the site, trying to reach all of the staff. But people are very busy. They have a lot of competing demands, and so these things have to be worked into people's workflow. And we had to check our referral processes were in place. We spent quite a bit of time leading up to the launch of our program, actually working with our referral teams and the people that were going to be receiving our patients to make sure we were able to access them. We had a smooth way in which our patients could access their services, and that they were able to handle the potential capacity of people coming to them. All of those are very significant considerations. So this was a teleform form, and I'll explain why we used this. We potentially had hundreds of patients that were going to be filling out these forms, and it had been identified by our colleagues in other sites that asking people at the point of care to do some of this documentation led to some challenges. Challenges in terms of completion rate, so people were being asked, but it wasn't being documented, so you couldn't report it, and then the team didn't know what was going on. Issues with people interpreting things differently, so they were interpreting what the patients were reporting and then having to subsequently document it, and does that lead to any errors? So we directly asked the patients to self-report. And there's some evidence that if you're asking people sensitive information, they're more likely to give you accurate information if they're able to not have to verbally say it to somebody, but are able to write it down. So we thought we would pilot that way. And these forms can be scanned. It's like if you've ever done a multiple choice exam and you have to bubble in the boxes and you scan it. This works in the same way. It has very fast scan rate. 80 pages per minute is very accurate, and you do have the ability to go in and do quality assurance on the data entry. It would automatically pull information based on their demographics. So this is their hospital unique identifier, and link it to their medical record. And so this was a very scalable solution for us to screen a large number of people and to get that data entered into our systems in a reliable way. And so what happened in the pilot? So this was those 3 sites, tried them for 3 months. And you can see here the distribution of patients that made up this pilot. Just under 1,000 people in the pilot were screened. The people that continue to smoke, as I said, head and neck and lung tend to be a bit higher, a little bit lower in the gynecological site. But again, very high interest in quitting. And we'll come back to that myth in a few slides, but you can see in the 80% range, so a lot of interest. And secondhand smoke exposure. So as we were launching our program, this paper that was published by Lawson and this data, we were analyzing, and you can see that in people that are exposed to smoking in their home, so they have someone else that's also using tobacco products, or they have peers that are using tobacco products, they are significantly less likely to have a successful quit attempt than people that don't have any other kind of exposure. So these are the people with a peer or home exposure in red, and the people that don't have a secondhand exposure are in black. And so we said that's very significant, and that's a big challenge to people. And so is there a way, these are family units, these are peer supports, they're critical to people's ability to go through treatment. Can we support the whole family? Or can we support these people's peers in having I guess you could say, group quit attempt? And does that actually make it more likely for our patients to stop, and also help people who are their supports in getting the benefits of cessation? So we modified the questions we were asking. And in these red boxes here, here, and here, we asked them about other exposures. And we told our teams, and we worked again with our referral groups to say, can we also refer people with the patient who may be interested, and they may be their spouse, they may be their children, and how we were going to do that. So we modified our program and implemented that as well. So this is our screening protocol in our original format. So they were given their paper form when they came to check in as a new patient. Different sites also have other forms that they might be given. Those responses were reviewed by their team and placed with their chart. If they were using tobacco and interested in a cessation opportunity or a referral, that was done for them. The teams had to do this through fax. And if they weren't interested, we asked the teams to give them at least the information about why it might be beneficial. So this could be revisited with them at another time. And so what happened? So we were able to implement across all the sites. We essentially had a rolling implementation, adding 2 or 3 sites every month so that we could work closely with them, work out any site-specific issues that might happen. We had multiple ways of reaching the sites. We met with their teams at their team meetings. We sent them email communications. We put this in some of our newsletters, really tried to reach people in multiple ways and say it to them multiple times. We worked with our patient flow coordinators and our patient care coordinators and the other leaders in the clinic. They were critical in terms of making this work, making sure our message was being properly delivered. And we tracked performance monthly, and we gave feedback to the teams on how they were doing compared to the previous months and how they were doing in relation to other teams, and that was very effective. So we found overall about 55% of new patients were being screened. It varied widely among the different sites. Some were 90 to over 100%, some were very low. And so that required a lot of iterative work with the teams to sort of understand why there was such a discrepancy. Could some clinics learn from the best practices of other clinics and sort of get that peer mentoring going on? This number remains steady. The number of people who currently smoked across all sites stayed about 17%. And that interest in quitting, again, stayed about the same. It varied a little bit across the sites. But where we were really falling down is that although there was this high motivation, we know that this is the time around diagnosis where you've got that teachable moment, our healthcare providers were not always following through with making the referrals, and that rate was very low, about 20%. So this really felt like a big lost opportunity where you've got motivated people interested in stopping, and for a multitude of reasons, those referrals were not happening. And we said, that's an area to be improved on. How could we possibly go about making those improvements? And so that's when we started collaborating very closely with our survivorship team. We do a lot of self-management research, and we were interested in patient activation and how we could close that gap. And so the grant that we got from the Ontario Cancer Research Institute was to pilot a program called CEASE, and I'll explain that. But it essentially used the ONLU model, which is a knowledge translation framework, to study the barriers that were leading to this gap that we've seen, to in a structured way implement our new solution, which was CEASE, and to evaluate the outcomes of that. So that process is actually still ongoing. We're essentially completing stage 3 now, but I'll show you some of the preliminary data, and it's been quite positive. So what were the barriers and supports when we started this? So we thought one of the main supports and what our teams expressed was that CCO framework and mandate, the leadership from our Princess Margaret team and also our UHN leaders, the support from the clinical teams. We had great engagement from all of our healthcare professionals. They really understood why this was important. They're very dedicated in terms of helping the patients. And there was high motivations from patients and their families about accessing these resources. So those were all very positive. And there were barriers. There's time constraints in clinic. I think we all feel that. There's still that lack of familiarity with cessation resources, and staff turnover is a reality that we all face. And you have to manage that, and you have to continue to provide that ongoing teaching, that rationale, and that support on the front line and that feedback. Oh, so I just got a question on the feed asking if we've ever addressed whether or not people had secondhand smoke exposure in the workplace. We didn't. So that study that was done by Lawsoning, that I showed the data for, it really focused on what was happening at home and what was happening with their peers. I don't know how to unpack if that peer relationship could be coworkers that they potentially spent a lot of time with outside of work. I don't know. But that's a great question. So I have one more. So there's one more question, and then I'll keep going. So the question was about specific strategies to engage physicians. So we engaged physicians along with the whole team. So when we would go and do education, our site-based rounds, we used our multidisciplinary tumor board. We actually asked for time to present there. And so we spoke to the physicians from all of the different disciplines, along with our leads in nursing, radiation therapy, dentistry, dietitians, whoever was at the tumor board. They all received the same brief education about why it was important, the rationale for the program, the mandate from Cancer Care Ontario, and they receive our emails in terms of feedback about the performance of the various site groups. And each of our site groups has a physician leader, and we work closely with the groups that struggled in terms of their screening rates and their numbers, about what else can we put in place to assist. But we had great reception from all, as I said, all of our healthcare providers, including our physicians. When I went to present, many of them said, you know, it's about time. Why did this take us so long to get here? And that was really positive in terms of having the support and the momentum to move things forward. So the purpose of developing CEASE, so this was the electronic platform, was to really facilitate the screening and access to the cessation services amongst our patients, and to try to pilot a patient-driven self-management solution. So we already had an iPad solution existing in our clinics because another one of our provincial programs through Cancer Care Ontario is distress screening using the ESAS tool. And so we have kiosks and we also have iPads that were already present in the clinic to do this screening. And so we worked with our ESAS and DART team to integrate the smoking cessation into the screening that was already going on. There were many reasons for that. It streamlined the workflow for our patient care coordinators and our patient flow coordinators. They didn't have to worry about giving out paper for one thing, iPads for another, or different iPads. From the patient perspective, you received one item that would ask you a multitude of questions. It was much more streamlined. And we did have to work with our IT teams in terms of making that integration, but the iPads also speak directly to the patient record. So we were able to directly do documentation without asking anybody to do any extra work. And so CEASE really focuses on 3 A's, so asking people their current status. There's a brief patient education materials built into CEASE, and there's an opportunity for them to expand out and gain more information if they're interested. And there's a simple automated referral system, and I'll walk you through some of that. So these are just some of the screens. This is the Ask screen, so you can see, so the reason it says DART at the top is that's the distress screening program that this is integrated with. And so it talks about the health benefits and it asks them, we use 6 months. That was our directions from Cancer Care Ontario. And so they say yes or no. If they say no, they're essentially thanked for participating in this. And if there's other patient-reported outcome metrics that they have to complete for the clinic, it would move them on to those other pages. If they do click yes on the preceding screen, this is some of the very brief information they receive. If they click yes, that they want to know more information about the benefits of quitting, it pops them out to another screen that actually has by disease sites and different cancer site information, so a bit more detailed. They don't have to have more information if this is enough, or there was already high motivation, they can just hit no and continue with the program. And then it takes them to, and there's a few more questions in there, but in the essence of time, I won't show you all the screens. And then the final page is an assist. So if they've indicated that they are interested in cessation service, they can register with one of the 3 of our programs, so Smokers Helpline, our CAMH Clinic, or our outpatient pharmacy. And we worked with those groups to give us a brief description about why they may find one or the other preferable. And if they don't want a referral or they just need a bit more information, then they can click this button. All of this information is printed and given to the healthcare teams as the patient's coming into the room for their visit, so they can review what they reported on the screens and also any decisions that they've made about referrals. And if we're here in this box about not wanting to be referred but wanting more information, or I want to quit on my own, they still have an opportunity to work with them on that, or give them information at least. So these are our iPads. That's what they look like. This is some more information we gather about how long you've used tobacco. And again, we did a similar rollout to when we rolled out our paper system. So we started with a few pilot sites. This time it's head and neck, breast, and the gynecological clinic. And the reason for selecting those sites had to do with the way in which the iPads and the screening works in the clinic. And then we had another larger rollout to our other sites. These sites that went live in January, they had more customization and other patient-reported outcomes integrated into the electronic system. And so that required a little bit more work in terms of our IT integration. So we saved them for our last cohort. So what was happening pre-implementation? So there's a lot of data on this slide, so I'll just walk us through a little bit here. But you can see this was the number screened in a several-month period pre-implementation to CEASE using the paper system. And you can see that it was several thousand patients. It was about half of the new patients that we'd seen. And so just going back to that Mythbuster that I talked about, where people would tell me, well, you know, Meredith, most people, they're not interested in quitting. A at the time of diagnosis. And I can tell you after talking, and we asked thousands of patients, the overwhelming majority is that they are interested in quitting and they are interested in the next month. And so this is very helpful data to show people. And then there was, again, that gap where we just weren't getting the referrals made. And so our overall referral rate was really only about 6% if you looked at the total number of people who were continuing to use tobacco products. So we implemented CEASE, and this is data from last spring. So when all the sites had been live for about 3 months, we started our first audit as to what was going on and trying to see the impact. So you can see already we're reaching a higher proportion of our new patients. This is just the CEASE data. Like all information technology systems, things happen. You still have to have a downtime procedure based on paper. Some of our new clinic spaces, we would learn that there's a Wi-Fi connection, which is how this gives us information into the main system. And in some areas, the Wi-Fi connectivity was intermittent, and so we had to install boosters. And so our team actually had to work with the DART and IT teams, and when the clinics would flag an issue, in this part of the clinic things don't work, they'd have to go in, they'd have to test the Wi-Fi strength and make some corrections. So this was 67% based on just CEASE. There was a very small additional percentage that was still being done in paper. We continue to have the paper downtime procedures. That is critical if you go electronic. You just can't avoid occasional issues. They're quite minor, but they do happen. And this number stayed about the same. So this willing to quit in the next month, that stayed quite stable. But you can see the recommended referral rate went up quite significantly to 84%. And that small percentage where they weren't being recommended a referral is where they're actually exiting the system before you can get to the opportunity to recommend a referral. So if they're saying, I really am not in a place to talk about this right now, that's coming out a little bit sooner. But you can see there's very different overall referral rates. So we were 6% when we use paper, and we're 27% when we use the electronic system. What is the number here? I don't know. Will you ever be 100%? I think that's unrealistic. But we certainly felt as a team that we were closing this gap where people who wanted more information, who wanted to go and access services, I think we were starting to feel that we were making progress in at least getting them there. So I might just pop back to the slide for 1 second and just close that out. I've given versions of this presentation a few times, and there are great questions that people have asked me about, more information about this. So what happens to them once we make a referral? How many of them have actually managed to be successful in quitting for 6 months or for a year? How many of them are following through and actually attending the referrals? So now that CEASE has been live for over 6 months, we've actually, and we've worked out a lot of the issues, not all of them. We implemented a few months ago a re-ask. So because they're given these iPads, we give them as a new patient, screen them for symptoms and screen them for tobacco. But they're given it every time they come for symptom screening, so not part of our program. And so we had an opportunity through smart technology to basically trigger them to be asked their tobacco screening questions again at their 6-month visit. So 6 months after originally completing CEASE, they're going to be asked again. So we have patients that are just approaching that 6-month follow-up point in the next few months. So we're going to start to gather data on what happened to them. So regardless of what they said, if they indicated that they use tobacco products at their initial screening, they will be re-asked the CEASE questions that are slightly modified, the education slightly modified because the majority of them have received their treatment, but we're trying to find out what happened to them. Did they make it to their referrals? Are they still using tobacco products? And if they are they still interested in going back and having a referral now? We may catch people that at the time, they just weren't in a place to go and talk about this, but maybe they are now. So to catch more people, and we've actually, this number is several thousand new patients. We actually had several thousand other follow-up patients that were caught through the screening, not for our Cancer Care Ontario program, but just follow-up patients that through the logic of the way CEASE works, were asked and offered referrals. And we thought that was a great win for them, because if people are interested in these services, it's important for them. It was great that it facilitated it for them. So we're closing in on the end, and I want to leave some time for questions, but I think we can all say that smoking cessation is an essential component of our cancer services. We have been so fortunate in the leadership by Cancer Care Ontario in this aspect. If you're coming from other provinces, I think there is great work going on in other places, but that type of provincial level leadership really was critical to success. You can implement screening across your programs, no matter how big or small they are. Electronic solutions we found were very feasible. We found that patient-reported outcomes were very feasible, and really capitalizing on those self-management principles, at least for us, helped close a big gap in terms of care. We haven't finished analyzing the CEASE data. We're obviously going to do some comparisons, but I think you can see that there's a real palpable difference in terms of the referral rates. But we have a ways to go. We do need that data on the long-term cessation rates. Somebody asked a great question, which I'm going to address as the first one. It's a good one. And what else? What about people that English is not their first language? And I had mentioned to you right at the beginning that we had translated some of our patient education materials. We're actually in the process to be implemented in the spring of translating CEASE into our top 5 languages, which I think is going to be very helpful for a proportion of our patients. And we'll have to audit that data and see how many patients elect to fill it out in one of the languages that we're able to translate it into, and whether or not that helps those groups receive services. We're going back and auditing our data to see of that percentage, that about 30% that are not screened as new patients. We're trying to see who they are. So we'll account for the people that used paper and then try to see what happened to that other percent. Was it language? Was it something else? And see if there's anything we can do to modify our program to help get that number even higher. And just there's lots of people to acknowledge. This is really a team effort. Rob and Victoria Milne are 2 of my program managers. Rob's actually now gone off to medical school. These are all members of our care team at Princess Margaret. The whole working group, they're really critical to keeping the energy up and bringing new and innovative ideas. Jeff Liu and Lawson Eng for their great research. Our patient education team for their work, and Mihaela is the research assistant who leads the CEASE project, and Kirby, as I said, led some of that UHN level work. So I'll just answer Christine's question about implementing CEASE. So it was, how do you accommodate different literacy levels? So we have plain language, all of the content in CEASE through our patient education department. And we do have standards at our institution about the literacy level. Health literacy is a major issue in Toronto, as it is in many places in Ontario. So we do try to abide by our standards that we use for our pamphlets and all of our patient-facing materials, but it was really critical to work closely with the patient education department on that. And I can see a few people are typing, so we'll just pause while they pop up. Oh, so there's a question from Brigitte about sharing the slides. So Tanya's actually just joined me. Did you want to tell them how they can access the slides?
Yeah, for sure. So you can access a PDF copy of these slides. They're available at the bottom right-hand side of the screen under File Share.
And I think Tanya had my email, but I am happy to chat with anybody offline. The links to our website and some of our resources are there. You're welcome to access those, and we're happy to talk to you over email about that. maybe we'll just give about 20 more seconds if there's any last comments. Oh, okay, yeah, thanks. So there was one other question about working with individuals with terminal cancer in our palliative population. So, yeah, that was a very common question we received from our site groups. We have screened everybody. Depending on the nature of the terminal diagnosis, sometimes it's about being able to manage symptoms. So one of my sites is lung cancer. The need for home oxygen can be something that needs to be very carefully managed if people still are smoking actively at home. And so managing withdrawal is very important, and people that end up having to be admitted to hospital for various symptom control. Dealing with nicotine withdrawal is something that really needs to be brought to the forefront. And so we've worked with our teams about that. And sometimes there's still high motivation on the part of the patient and their families. And so there's still an opportunity there. And so we make our services available to everybody. So there's a question from Hillary. How did you receive funding for the iPads? So as I said, some of the iPads were funded from our symptom screening group. With our grant, we were able to fund a little bit additional hardware. Part of our implementation, that first part of the en route process, was to actually work with our clinical teams and say to them, what are the barriers here? Because in some of the very busy clinics, sometimes you need more resources. So we would go and audit and work with them and say, do we have enough iPads here? Are they distributed in the right place? It's accessible for patients. And so that is ongoing. That is something that's ongoing. Like any IT, it requires maintenance. There's upgrades that have to be managed. We work very closely with our IT team. Things break. I have to say we don't lose many iPads. They're put in a sort of protective housing. We don't get a lot of broken iPads, but you do have to have some principles around that. Thanks, everybody. So I'm just going to turn this over to Tanya.
Oh, there's one more question. Is CEASE linked to your EMR?
Yeah. So there was one last question there about CEASE being linked to our electronic medical record. So it is. Our teleformed paper data was also linked to our medical record, and so is CEASE. And so the team can see the information. It's stored in a secure way. Yeah, so both were.
Okay, if you think of any more questions, please feel free to continue typing them into the chat box, or alternatively, you can email me. My email address is at the side here with your question, and I'll be sure to forward them on to Dr. Giuliani. So thank you so much, Dr. Giuliani, for such an informative presentation. I hope everyone else enjoyed it as well. Just a couple of reminders that you will receive the link to the post-learning assessment and evaluation today. Please be sure to complete the post-learning assessment in order to be eligible to receive a letter of completion. And again, if you participated as a group, please be sure to email me by end of day today with a list of the attendees so that we can record your attendance. The next Teach educational rounds will take place on Wednesday, December the 7th, so coming up in just 2 weeks. Registration period is now open, and the topic will be the STOP program, Client-Centered Care with Dr. Peter Salvi. If you missed the beginning of today's presentation, want to view it again, or want to see previous Teach webinars, not a problem. You can watch our archived webinars through our website, www.teachproject.ca, and just follow the instructions on the page here. So thank you everyone for attending. We hope you enjoyed it and have a great day.